Hello, this is Shawn Hamilton, Clinical Product Manager here at Access. And today I would like to demonstrate the Summary of Care tab within the OASIS-C2 assessment. Now, the Summary of Care tab is a little different than what it was in the past OASIS because of all the different regulatory updates by Medicare. So to begin, we start with the first service line for the plan of care. So the first service line for the plan of care for the skilled nurse, and I will also show you the first line of service for therapy, but today, well, for right now, I'm going to start with the skilled nursing. And then later, I will show you this section for the therapy, because the top section is really the only section that is different for nursing and therapy. The rest of the sections are basically the same. So to begin with this first section, there's basically 4 different decisions that a nurse can choose from. Either the patient had a start of care, they had an evaluation actually, and there was a need for skilled nursing services that was identified. So again, it's going to be very important that you indicate what the patient's primary disease process is. And that's, with the emphasis on, you're listing out the disease process for the people who are doing the coding. This is per guidance and regulations. The nurse in the field is supposed to identify what is the primary reason for home care. So this is where you document that. And then it says skilled nurse to assess other comorbidities. And this is where you want to identify those disease processes that will affect your plan of care, that you will assess, not necessarily teach on, but you will assess. And if there are any problems, you will notify the physician promptly and determine whether or not another plan of care needs to be developed for that particular disease process. If the patient does not require skilled nursing, another decision is that this is a therapy-only case. So you receive an order for a therapy-only case for the nurse to actually go out and perform the admission. So you need this order on the plan of care to identify that the nurse is actually going out to collect the OASIS data. And this data must be collected either on the exact day that the therapist is going to do their evaluation or within the 5-day window. So if the nurse goes out on day 1 and the therapist go out on day 2, then that OASIS is null and void. The nurse must go out either the day the therapist go out or within the 5-day window after the therapist does their evaluation. Now, it says the nurse must go on the same day. So even if the nurse goes before the therapist completes their evaluation, as long as it's on the same day, that's all that really matters. The third option would be the management and evaluation of the non-skilled plan of care. So if this start of care is for a M&E patient, then you're able to identify that here. And just remember that a physician addendum is required. So if you're going to do management and evaluation at a start of care, you need to ensure that you have a physician addendum that was signed by the physician, or it won't be accepted by Medicare. And then the last option, of course, would be that the skilled nurse evaluation was performed, but there are no further visits required. And if that is the case, then that patient is going to be a non-admit. You're able to click non-admit, and then you can put in a communication note to your clinical manager so that they know that the patient is a non-admit, and you have documentation as to why the patient is a non-admit. So the next one is the additional physicians on the case. So this is where when you go to see the physician and they're telling you, this is who their cardiologist is, you're going to add that information here. If this box was not checked upon the referral that the physician was contacted and agreed to care plan oversight for this patient, it should be checked before the nurse actually gets the admission. But if it's not, you want to check that box for documentation purposes, because Medicare have as a part of their rules that the physician must be contacted and agree to care plan oversight. Okay? Especially if a hospitalist is certifying the patient and sending the patient home with orders. The primary care physician must agree to the care plan oversight. Certification for skilled care. This is very important because this right here, I certify that the patient is confined to home. This is the information that will flow to the actual plan of care. And so you want to be sure that you check that information. It's very important to put that face-to-face physician visit there as well. You're able to put the management and evaluation information here. And if your company have its own set of templates for physician certification, you can just access it here. And then it says need for oral explanation of patient rights by the second visit. If your patient has a language deficit and you are unable to actually orally explain their patient rights to them, Medicare will allow you to get an interpreter and to explain those rights by the second visit. So you're just documenting here that it wasn't done. You're acknowledging that, and that information will be on the plan of care so that it can be completed by the second visit. The next thing here is the physician information. So you want to enter the last visit date. If the face-to-face information is complete, and what I mean by complete is that you're the clinician, you're out there doing the visit, and every medication, when you do the medication reconciliation, all the medications match up, and the patient is not telling you that they have a pacemaker and you don't see that anywhere in the physician documentation, or they're on medicine for heart failure, but you don't see heart failure. So if any of those things happen, then you have to document here that the information is incomplete. And we also give you some cues of different things to look at as well. So if the information is incomplete, such as I just spoke of, say patient has CHF, the doctor doesn't mention that, or as usual, they do not identify what the patient's homebound status is. If the doctor does not identify the patient's homebound status, and I'm not talking about check marks, if they do not document a narrative reason for why the patient is homebound, you will have to ensure that that information is in your addendum. We actually put it on the plan of care. We make sure that that information does flow there. But if an addendum is required, you're going to check that an addendum is required. What checking that checkbox mean is that you have physically called the physician and you have stated to the doctor that, this patient has CHF, but it's not in the medical record here. Is it okay? Does this patient have CHF? Is it okay that we update the medical record? And so you would update that information there. If the patient requires a follow-up visit with the physician for the completion of the face-to-face requirement, you're going to check that as well. Now, if they require a follow-up visit, you want to ensure that the patient understands exactly what that means. So you can document that you instructed the patient on the face-to-face regulation, you assisted the patient with making the appointment if you did, and that you have identified any barriers to getting the face-to-face completed. If that is the exact case. That may not be the case, but if it is, you're able to document that there. And then you can put in your comment. If there are labs that need to be drawn, you're able to indicate that information there. Infection control is extremely important. So you're able to document anything regarding infection, whether or not they have knowledge deficits. If the patient came to you with an infection, then that would be considered a nosocomial infection, and you want to ensure that you identify that the patient was admitted to your agency with that infection versus the community acquired, which is at least 72 hours post-hospitalization. You want to be able to put that there. Now we start getting into a lot of this new information regarding building a individualized patient plan of care. And the reason why this is important is because we can develop plans of care for patients all the time, but if it's not of interest to the patient, then the plan of care will not matter. And so this section here, as far as the patient's area of interest, these are generally the sections that inform self-management. So you want to know, does the patient want to learn how to take their medications, what to eat, anything about activity and exercise, how to manage their symptoms, when to seek help, how to stay out of the hospital, and where to get information. And then you can add other, whatever else they may want to know. And then this section right here, the patient goal, patient personal health care goal. This is very important because when you're dealing with patients, we can't just write a bunch of goals for them. We have to identify where they are mentally, physically. And so if the patient is depressed, or if they're having pain, for instance, they may not feel motivated to do much of anything. As a clinician, we're trying to find out what their motivation is, because you want to identify early things that are barriers to your plan of care. You don't want to develop a plan of care and then get, sideswiped. You want to think about these things initially. And so maybe the patient, have a goal that they want to go to their granddaughter's wedding. So that's what will motivate them to perform the various therapeutic exercises that the therapist is trying to get them to do. Or maybe the patient, they have decided that, I don't want to give up eating ice cream, but instead of eating it every day, maybe I can try to get to 2 to 3 times a week. It's important to identify what their personal goal is for their health care, what they really want to accomplish. It's going to be hard for them to, know, that they wish their ejection fraction would be this versus that. Their hemoglobin A1C. A lot of them may not even know the normal range for hemoglobin A1C. So as you are developing that plan of care with them, their hemoglobin A1C is at a 10, and you want to work with them, to try to get it to at least a 8 or maybe a 9, just to have some type of incremental success. Those are the things that you can try to work with them on. Now, the coordination of care, that part is not new. We're going to continue to do that. This plan of care review. So everything I've said, we have the plan of care review, and you have to identify if you have developed and reviewed this plan of care and the goals with the patient selected, or the legal representative. So we give you the ability to document this information here. This is a must. It's a conditional level deficiency if we do not document that information. And then we have the patient response. So just about all of this must be filled in, okay? The patient response is you want to know if they're willing and able, unwilling, or unable, or do they have barriers that will impede their full participation? This is not only important for therapy, but it's also important for nursing. We have to think about those things that, again, will impede the patient's plan of care. The goal for Medicare is patient improvement. We have to function all of our thinking on improved outcomes. So just think about that when answering that. And then the patient selected representative response. If they have a representative, it's basically the same response. You have to say, what their willingness is all about. The involvement. Patient selected legal representative involvement. You want to know, are they going to be involved? Patient able to identify people who may be able to assist in reaching goals. This is crucial. You want to ask them, who can help you to accomplish these goals that we are identifying that you need to improve your health status. And then, again, this is conditions of participation. You have to enter the caregiver availability and the type of assistance. So it's important to know if, daughter Joe, assist the patient with grocery shopping. You want to write that, 2 times a week, or, whatever assistance they have, you want to be able to write that. Because if I have a patient that lives alone is depressed, have pain, and on assessment, I can see they're already having medication challenges as far as their ability to take their medicines, and they live alone, and the daughter come by one time a week. Well, immediately we're going to have to get on the phone and see, what type of help the patient is able to receive. And then you're able to enter your other comments. Now, this emergency contacts, this information is here, and it's important because you're able to enter any new emergency contacts. You can add additional people here. Most of the time, this information isn't known until the clinician goes into the home, and then they're able to enter that information there for any additional contacts. Patient strengths. So we looked at, what are some of the different weaknesses. We also want to know, what are their strengths? Are they motivated? Do they have a strong support system? A person with an absence of multiple comorbidities, a lot of times those are the 55, 60, 65-year-olds that we get who are knee or hip patients, and they don't really have a lot of comorbidities, maybe just hypertension. Those patients are generally easier to take care of. Are they a high school graduate, enhanced socioeconomic status, college graduate? Those are things that we're able to look at. Now, this next section is called first visit interventions. First visit interventions are extremely important within the legal ramifications for Medicare. And you have to answer all of these sections. So the first section is the legal section. And you want to identify if the patient received the written patient rights and responsibilities. If they received it, you check it. You can type your response here for how you want that to be documented. Medication review. You want to document if you completed the medication review and assess for drug interactions. You want to be able to document if you had to reconcile the medications because there were discrepancies, and whether or not you instructed the patient to ensure that they are safe until the next visit. Medication errors are one of the major calls for patients to be back within the hospital within 3 days. So it is extremely important to ensure that the patient can take their medications correctly. The disease process. You want to instruct them on what necessitates an emergency, number one, and who to call. So the green, yellow, red information that is used often from HHQI is so vital on admission that patients understand, to call their nurse first. So there's also a campaign, Call Me First, but they need to understand what necessitates calling 911 because sometimes, unfortunately, they may have to call 911. This is why it's also important for, there's different campaigns that are going on, and one of them is Contact 3. So usually a patient will come on to home care and they are seen. Patients who are identified for high risk are seen once every day for the first 3 days by at least one discipline. So those are different things that will need to be looked at from an agency point of view. But again, high risk hospitalization is, something that all agencies need to really focus on. Safety is extremely important. We want to identify that you have instructed the patient on safety measures to prevent falls. So even though it's not your full fall teaching, we need to hit some sort of fall teaching upon admission, as well as infection control. Every agency must have an infection control program, and teaching infection control in the home is a part of it. The emergency care plan review, you must document that the patient was given an individualized emergency plan of care, And then there are 2 items here that, based upon your agency policies and procedures, you need to look at. One of them is that you identified that the patient will require assistance during an evacuation. Any essential equipment is needed. So again, on our risk tab, you're able to go and update the emergency care planning information there. And then contact made to register the patient with local state authorities for needing assistance during an emergency. Now, if you don't do that on admission, there must be some sort of process or procedure for ensuring that all patients that are a level 4 or any patients that actually require assistance leaving the home, that you have actually registered them with the appropriate authorities. And that information is documented in the patient chart. Another thing that is in the conditions of participation is around this idea of disciplines and scheduling. And so you have to document that you instructed the patient and their representative regarding all disciplines on the case and developed a plan of care for scheduling, that the patient agrees on the need to develop the overall schedule with the individual services as well. What that means is, of course, if I'm the clinician, I'm a nurse, I'm going out to admit the patient, I don't know what their schedule with physical therapy is going to be. The patient is going to have to set up that information, get that information from the therapist, because I have no idea if it's going to be 2 week 2 or 2 week 4. So that is the information there. So every single discipline must set up their schedule with the patient and coordinate with each other, of course. If your agency, have any additional first visit interventions, of course, you can develop templates and you're able to pull that information in. If you don't want to use any of these suggested items, that's fine as well. There need to be some sort of verbiage pulled in regarding the scheduling. Physician contact. Physician contact. You must contact the physician regarding initiation of the home care services per physician orders with plan of care to follow. I'm not sure if every clinician is aware of this or not, but it does affect your license. When an agency receives an order to admit a patient to home care, that does not mean that they have orders to continue seeing the patient. Once the patient is admitted to home care services, or you determine that the patient is in need of a skilled care, you will need to call the physician, and surely they're not going to sit on the phone and discuss every single goal, and that is fine. You need to call the physician, especially if there are any changes to the face-to-face, and you need to let them know exactly what your primary reason for seeing the patient is, any pertinent orders, and that the plan of care will follow. And that is A-OK, because the information must be incorporated into the physician's medical record in his office, and the physician must provide care plan oversight. If the primary care physician is not the certifying physician but agreed to the care plan oversight, you definitely must document that you contacted that physician. The agency is supposed to document this as well, but the clinician that is in the field, you have to document that you had contact with the physician that is providing oversight, because that is the person that you will send all of your additional orders to. And depending on the rules of your certifying physician, some hospitalists, for instance, will not sign orders. If they're not going to sign the order, then they're not the certifying physician. The certifying physician is the person who is signing the orders, not the person who is giving the order. And then you identified all additional physicians with the patient. That's important. If other doctors are actually giving orders, the primary care physician is the primary care physician, but my patient has a cardiologist and he's giving me orders for PT-INRs because my patient is on Coumadin, I must include that physician in the plan of care. So you're able to do that here. And then It seems like a lot, but it's there for you, broken down easily, to document what it is that you need to document and to ensure that your documentation is actually complete. So when we go a little bit further, any interventions, so anything that I teach the patient, I'm here for CHF, so I'm going to pull in my templates or document my visit number 1 instructions for CHF. I'm going to put that information here in the response to teaching. The visit narrative. This visit narrative is actually the place where you will document your assessment information, why this patient is requiring skilled care. I know it's in different parts of the assessment here, but that face-to-face information, those things that are not included in the face-to-face documentation that you have gotten from the physician, you can pull it here. Most agencies have a visit narrative. You're able to pull that in. This is very important. This information will actually flow to the plan of care. So when the plan of care goes to the physician, your visit narrative would go to the physician as well, because Medicare states in order to consider that as part of the face-to-face documentation, the physician must sign that information within the plan of care. So that's going to be very important. And then the last thing is, of course, the rehab potential and the discharge plans. That information is the same. We haven't changed it. And then you're still able to put in your frequency here. So when you put in your frequency for, let's say if you're a nurse and you put in your frequencies, if you ordered a PT eval, you're going to put it here. And even though the physical therapist is going to have their own therapy frequencies, you still want to include the eval within the nursing portion, because the physical therapy evals will be pulled into the plan of care. So I want to show you next what the therapy portion at the top. So for the first line of interventions, if you are a therapist, then you will see these tabs listed here. So the first tab is the need for restorative therapy. So if your patient is in need of physical therapy, occupational, or speech therapy, and they need further visits, then you're able to check this information here. And this is the verbiage that will appear on the plan of care. If they need maintenance therapy, then you're able to check that information, and that's what will appear. So quite naturally, they cannot have restorative and maintenance therapy, so you can choose one or the other. And then again, if therapy evaluation was performed, no visits required, you're going to hit none admission. If you actually did a physical therapy assessment or speech therapy assessment, but there were no needs, but the nurse needed to come out because you got there and you saw the patient was having a mess with their medicines, then you can write an order for the RN to evaluate the need for nursing services. And then the rest is the same as I just showed with the nursing, the additional physicians, the physician certification statement, and the need for oral explanation of patient rights by the second visit. Thank you so much for your time. I hope this session was beneficial. And if you have any questions, just let us know. Thank you.